prestigious and elegant conference as usual. I'm going to talk about a very tough subject. You know, we can write books about it. It's very difficult to cover in 15 minutes. So just I'll do my best to be as fast as I can and to try to cover as much knowledge as we can. I have no disclosures concerning this lecture. So I will talk about dysplasia of the esophagus, stomach, biliary tree, and we'll end up by the colon, which is most important for most of us. So first, the definition of dysplasia. As we know, it's a term used to describe the presence of abnormal cells within a tissue or organ. Dysplasia is not cancer yet, but it may sometimes become cancer. And dysplasia can be mild, moderate, or severe, depending on how abnormal the cells look, and microscopic, and how much of the tissue or organ is detected. Also, it's important to know the difference between dysplasia and metaplasia, because sometimes I see some some junior colleagues, they have some confusion between both terms. You know, metaplasia is a change of cells to a different type of cells, like the most common or the most famous in our practice is parrot esophagus, and also what we see in the stomach with chronic infection, intestinal metaplasia. And dysplasia is different. Dysplasia can lead to cancer, while metaplasia does not. So we'll go first to the esophagus. Of course, I'm not going to talk about parrot. I know it has been covered thoroughly with different colleagues. Just we'll talk about dysplasia and what we should do if we find dysplasia. So if we do endoscopy and find parrot and we take biopsy, if there is no dysplasia, so the chance of developing cancer is very low. As we can see, it's as low as 2.2 to 0.5%. And then if we find only atypia of the cells, here the chance is still unknown. So for low risk dysplasia, the chance is 0.7%, and for high grade dysplasia, the chance is 7% almost to develop cancer, and these numbers are very rare. So what to do if we find dysplasia? This is very controversial, especially in the era of low-grade dysplasia. So let's see what the AGA recommend. This published this year, the guidelines of AGA. So the first recommendation, individuals with parrot esophagus and high-grade dysplasia, the AGA recommend endoscopic eradication therapy over surveillance. And for those with parrot esophagus with low-grade dysplasia, the AGA suggests also to do eradication endoscopic treatment over surveillance. So it's not recommended anymore to surveil patients with high-grade dysplasia. It's still indication for management. And an individual with non-dysplastic parrot esophagus, the AGA suggests against the routine use of eradication endoscopic treatment. So no need to do anything if it's no dysplasia detected. In patients underlying eradication endoscopic treatment, the AGA suggests resection of the visible lesion followed by ablation of the remaining parrot esophagus over resection of the entire segment. So here we can use combination of radiofrequency then to be followed by EMR or ESD. In individuals with parrot esophagus, in individuals with parrot esophagus with visible neoplastic lesions that have undergoing endoscopic resection, the AGA suggests that use of either EMR or ESD based on lesion characteristics. So what are the difficulties we are facing in such lesions? This is just a simple diagram for how does it look normally and in parrot esophagus and patients with dysplasia low grade and high grade, and even reaching to adenocarcinoma of the lower esophagus. And here is also example for a patient with parrot esophagus who discovered to have high grade dysplasia, was treated by ESD for resection of this segment. So let's leave the United States and go to Europe and see
why there is some difficulties in treating dysplasia in esophagus with parrot esophagus. The SGE recommends offering endoscopic eradication therapy using ablation to patients with parrot esophagus and low-grade dysplasia on at least 2 separate endoscopies, both confirmed by second experienced pathologist. This is strong recommendation. So it's not allowed to judge a patient with only one endoscopy and only one biopsy. They should do it twice. And every biopsy should be reviewed by 2 expert pathologists, and both of them they should mention that this patient is having low-grade dysplasia. And also it's very important that the patient has no reflux, I mean no erosions, no inflammation. They also suggest that low-risk submucosal invasion or vascular invasion and no poor tumor cell differentiation can be treated by endoscopic resection, provided that adequate follow-up with gastroscopy, endoscopic ultrasound, and CT or PET scan is performed in expert centers. So here we need an expert pathologist and we need an expert center to be able to follow up those patients. So we'll go for the stomach now. For gastric dysplasia, it's a precursor, as I mentioned, lesion to gastric adenocarcinoma. It can be flat or polypoidal, which is adenoma, and here I need to emphasize that adenoma by itself per se is dysplasia. So when I see adenoma, so it's dysplasia, either in upper GI or lower GI tracts, or arise on the surface of an existing non-dysplastic polyp. So that lesions might be treated with endoscopic submucosal resection or dissection. It's mainly more common in males, high incidence in Asia, Eastern Europe, and South America. H. pylori is still the most common cause worldwide. Smoking, radiation exposure, and occupation in rubber manufacturing also are risk factors. Predominantly asymptomatic, hence comes its difficulty to early diagnose. Although larger lesions may cause bleeding or anemia, it can present as flat, ulcerated, or polypoidal lesions on endoscopy. So for microscopic description or microscopic types, this gastric dysplasia is divided into several subtypes. The first is intestinal and fibular type are the most common. Crib dysplasia and serrated dysplasia are more recently classified, but are recognized subtypes in the World Health Organization. And tubular neck or glopoid dysplasia is a rare precursor lesion to poorly cohesive gastric cancer. And how it looks in endoscopy. So if you are using a standard definition endoscopy, you can miss this lesion easily. And this lesion mostly will lead to cancer if not treated or resected. So we'll go now for, I can say it's a bit neglected or not very well understood kind of dysplasia, which is found in bile ducts, mainly in the CBD. So now we are having, according to the latest classification, we are having 4 types of bile duct dysplasia. The first one is biliary intraepithelial neoplasia, which is called PIL-N, is a microscopic flat or micropapillary lesions of the dysplastic epithelium. Since it's a microscopic disease, PIL-N produce no symptoms and cannot be detected using current imaging method. It's most likely found in a specimen of invasive biliary tract cancer or in gallbladder resected for cholecystolysis. So it's almost impossible to look for or to diagnose PIL-N for a patient because it produces no symptoms and no modality of imaging are able to detect it. The second type is intraductal papillary neoplasia of the bile duct. So it's called IPNP, sorry. So we are very familiar with IPMN of the pancreas, but this is the IPNP. It's a macroscopic lesion that can present either single or multiple form. I was discussing with Dr. Maher just a few minutes ago about a case like this he saw in his center. It's situated along the biliary tree. It's characterized by intraductal growth of dysplastic epithelium with mucin hypersecretion. It was formerly known as biliary papillomas or biliary papillomatosis and papillary adenomas. Its current term is now recognized by the WHO on 2010. That is how it looks. As you can see, it can be diffuse or it can be localized. Also, it can lead to a structure, as you can see on lower right-hand side. So it's also intraductal tubular or tubular neoplasia. some case series have reported rare types of non-invasive intraductal bile duct tumors, intraductal tubular or tubular papillary neoplasm. They are characterized by tubular architecture, sparse formation of papillary elements, and minimal or no mucin production. It was further described by Yagamuchi et al. Its pancreatic counterpart is defined as an intraductal, grossly visible, tubular forming epithelial neoplasia with high-grade dysplasia and ductal differentiation without overt production of mucin. The last type is mucinous cyst neoplasia. We used to say before mucinous cyst adenoma or cyst adenocarcinoma, so now this terminology is changed to mucinous cyst neoplasia. The papillary mucinous cystic neoplasia are rare tumors characterized like their counterparts in the pancreas by presence of the ovarian type stroma and absence of communication with the biliary tree. They predominantly occur in females, formerly referred to be as the bile duct or biliary cystadenoma or cystinocarcinoma. So now the mucinous cyst neoplasia can develop in extrahepatic biliary ducts. However, as most of them are interhepatically, they are also called cystic neoplasia of the liver. They are classified based on the grades of dysplasia, low, intermediate, or high grade, or in association with invasive carcinoma. This is how it looks by CT. As you can see, it's a very large cyst, non-communicating with the biliary tree, with hypodense soft tissue seen on the upper left side. So now for the colon, which is, I think, the most important for all of us because we all see patients with IBD. So what can we do for patients with dysplasia in IBD? So the AGA's latest guidelines was 2021 for treating patients with IBD. Of course, I'm not talking about polyps because polyps was thoroughly discussed also. We'll talk about dysplasia with IBD. So we had some old names, sometimes still being used till now, like the adenomatous polyps, adenoma-like mass, or dysplasia-associated lesions or mass, or DULM, which is no longer be used, and flat are old terminology and should not be used anymore. Now, the precancerous colorectal lesions in IBD should be described as polypoid if they protrude more than 2.5 millimeters above mucosa, or non-polypoid if they protrude less than 2.5 millimeters above the mucosa, or invisible, so it's only detected with on-target biopsy done by the endoscopist. The visible precancerous lesions should be described based on size, morphology, clarity of borders, presence of ulcerations, locations, presence with area of past or current colitis, and perceived completeness of resection, and whether any surgical techniques were used for visualization. So how do we detect dysplasia? Shall we do just colonoscopy and take random biopsies? No, this should not be the case here. It should be targeted biopsy. This is the best option. So the screening initiation should be after 8 to 10 years of diagnosis, or if the patient develops PSC, it should be started now, and it should be done every year. So to optimize the detection, all inflammatory disease should be well controlled. So it's not recommended to take biopsy with patients who have active disease, either UC or Crohn's disease. High definition endoscopy plus dye spray chromoendoscopy should be the standard of care, and we should not use standard definition endoscopy anymore. We have to get excellent bowel preparation, careful inspection, target samples of suspicious mucosa, and endoscopic resection more than biopsies when lesions are clearly demarcated without stigmata of invasive cancer or submucosal fibrosis. This is an example how dysplastic lesion might appear during endoscopy. And again, here I say if you are using an SD scope, you will not be able to see this lesion. And also on your right-hand side or your left-hand side, there's with dye chromoendoscopy make the lesion more evident. So how can we manage it? So management of visible and invisible dysplasia with colitis. So if the lesion is less than 2 centimeters, and resectable, I mean it's a clear border, no features of submucosal invasion or fibrosis. Plus, there is no histological features of invasive cancer, so it should be managed by endoscopic resection with continued surveillance. And next endoscopy, okay, just 1 minute. It should be done in 3 to 6 months if there's high-grade dysplasia or incomplete section, and it should be done after 1 year if it's more than 1 centimeter or leg dysplasia, and it should be done after 2 years if it's less than 1 centimeter with low-grade dysplasia. So if it's large, I mean by large more than 2 centimeter, so also endoscopic resection with invasive surveillance versus surgery every 3 to 6 months for the first year. Decision to resect based on lesion details, local expertise, and disease activity. So if there is unresectable due to size, location, or whatever, patient should go for surgery, of course. And for invisible, so this is the most controversial part, invisible dysplasia, which is being diagnosed based on non-targeted biopsy or subtle polydelaminated lesions. So we have to confirm histology with second pathologist and treat inflammation and perform dye spray chromoendoscopy, and the use of chromoendoscopy to unmask capital lesions if no lesions seen. Then take extensive non-targeted biopsies in areas prior to dysplasia. So here, management with no visible dysplasia again. If I do a second colonoscopy and I find again persistent high-grade dysplasia, I go for surgery. And if there's persistent unifocal low-grade dysplasia or no histological dysplasia, we can go for intensive surveillance with dye chromoendoscopy again. So it's different between the past. In the past, we used to say if patient is having dysplasia, either low-grade or high-grade, he should go for colectomy. Now, no, he can go for only surveillance. And these are the timings when to do colonoscopy. It's also very important. We do it after 1 year if moderate to severe inflammation. Patient with PSC, as I mentioned, family history of CRC. Want to do every 2 to 3 years, and mild inflammation, strong family history of CRC, but there is no FDR, I mean age less than 50. Features of prior severe colitis, history of invisible dysplasia. So want to do it after every 5 years, continuous disease remission since last colonoscopy with mucosal healing on current examination, plus either of more than 2 consecutive exams without dysplasia, or there's minimal historical colitis extended less than 1/3 of the colon. So for wrap and take-home message, GI tract dysplasia is challenging and sometimes difficult to diagnose. Regular surveillance is the key to reach dysplasia before it transforms to malignancy. Extensive and continuous training for endoscopists is required. AI will play a key role in detecting GI dysplasia. Cooperation with the pathologist and radiologist is essential to reach a correct diagnosis. Thank you so much.